Hello my dear friends, welcome back to the version 2 of part 3 of my pulmonary hypertension series, which is on treatment of pulmonary hypertension. I hope you've already seen the previous video, which is the version 1 video, which talks about the general treatment of pulmonary hypertension as well as the drugs, their indications and their mechanism of action and doses. In this short video, I'm going to talk about two groups of pulmonary hypertension that we deal with most commonly and we are mostly concerned with, which is connective tissue disease and group 3 pulmonary hypertension. So let's quickly get started. So connective tissue disease related pulmonary artery hypertension is very common. It can happen with systemic sclerosis, SLE, mixed connective tissue diseases, sometimes with dermatomyositis and patients with Sjogren's syndrome. Now this after idiopathic pulmonary artery hypertension is the second most prevalent type of pulmonary artery hypertension, and it has more female predominance to the tune of 4:1. So whenever we see a patient with connective tissue disorder, connective tissue disease related ILD, we must rule out pulmonary hypertension. Now it's essential to remember that the drugs used for pulmonary artery hypertension can be prescribed in pulmonary artery hypertension related to CTD according to the same treatment algorithm. So that same treatment algorithm which we saw in the previous video, and I will be linking it here in this video as well for you to go back and reference, the same algorithm can be used in CTD patients. So we do not need newer medications. One point to remember is that sometimes when you treat your patients with connective tissue disease with immunosuppressants, or you use glucocorticoids and immunosuppressants or cyclophosphamide, then their pulmonary hypertension may improve, especially in SLE patients or patients with mixed connective tissue disease associated PH. But that does not mean that immunosuppressives or steroids or cyclophosphamide have a role in pulmonary hypertension per se. So treat the cause, treat the disease, and you can have an improvement in PH in CTD, but it is not recommended for the PH alone. Patients with systemic sclerosis and CTDs often have ILD. They often have a preserved heart function, preserved ejection fraction, but yet they land up into heart failure. So consider those points. If they are in heart failure or they have ILD, then additional requirements like oxygen supplementation, maintenance, giving medications for the heart failure component may be needed. Also, because systemic sclerosis, there is a very high risk of bleeding in certain populations like thrombophilias, antiphospholipid syndrome, patients who can have a risk of diffuse alveolar hemorrhage. So in these patients, if you decide on anticoagulation, you have to be very careful. So the long-term risk benefit ratio is important in these patients because there is a risk of bleeding. We can give vitamin K antagonists, however, in PH-CTD with thrombophilias, but anticoagulation is unfavorable otherwise. And also, patients are eligible for being listed and referred for lung transplant, so that has to be kept in mind. So this is the recommendation table taken from the guideline, which says that in patients with PH with CTD, treatment is according to the regular guideline algorithm, and the same algorithm is to be used. Coming next to the other group, which is of great interest to us as pulmonologists, which is group 3 PH, which is associated with lung disease or hypoxia. So most commonly we see COPD or emphysema or ILD related pulmonary hypertension. There are cases with combined fibrosis and emphysema and patients with hypoventilation syndromes and obstructive sleep apnea. Well, obstructive sleep apnea solely may not be a reason for a severe pulmonary hypertension, but usually in the form of overlap syndrome or patients with daytime hypoventilation, patients with CTPH, we may have an increase in pulmonary hypertension secondary to OSA. So this group of patients will have more pulmonary hypertension. And even non-severe pulmonary hypertension in any lung disease negatively impacts the patient's overall symptoms, the survival. There is more hospitalization even if the pulmonary hypertension component is non-severe. So that's very important to keep in mind and manage them both together. High altitude pulmonary edema, high altitude hypoxia induced pulmonary hypertension can also occur in a 5% of population and has to be kept in mind. And this is categorized into two categories mainly, which is non-severe and severe. If you look back at 2015 ERS-CSC guidelines on pulmonary hypertension, the division into severe and non-severe was based on mean PAP. But now we do not use mean PAP. There, mean PAP more than 35 or more than 25 with a cardiac index of less than 2.5 was supposed to be dividing severe or non-severe. But now we talk about pulmonary vascular resistance. So pulmonary vascular resistance of more than 5 Wood units or less than 5 Wood units would distinguish severe and non-severe pulmonary hypertension in lung disease. So how does this whole pulmonary hypertension thing impact the lung disease? So if you look at the pathophysiology of PH associated with lung disease, you would notice that the lung diseases like COPD or ILD or combined fibrosis cause emphysema, remodeling of airways, remodeling of lung parenchyma as in fibrosis, or remodeling of the vessels as in vascular pruning. So if you look at it, the more the remodeling of airways in the parenchyma occurs, proportionately the remodeling of pulmonary vessels and vascular remodeling starts. And this determines the degree of pulmonary hypertension and causes its consequences of exercise limitation, whether it being a ventilatory limitation initially, it may progress to a circulatory limitation of exercise eventually. So treatment of the pulmonary hypertension component is important to make sure your patient does not experience hypoxemia or exercise limitation. So here you divide it into no PH, non-severe PH and severe PH, and you see most patients will not have pulmonary hypertension initially, but 5 to 10% may land up to have a severe pulmonary hypertension. There is also a phenotype which is described, which is called pulmonary vascular phenotype. In this group of patients, the spirometry is preserved. So there is no COPD or ILD obviously visible, but this patient will have a low diffusion capacity. These patients may complain of hypoxemia, and when you do a scan, they may have or they may not have enough of parenchymal involvement too, but they will have a circulatory limitation to exercise. So these group of patients where the spirometry is normal, the DLCO is low because of the vascular component, they are hypoxic and they have a limitation to exercise, evaluation of the pulmonary vasculature becomes very important. What do you do if you suspect pulmonary hypertension in a lung disease? Number one, you look for presence or absence of risk factors for pulmonary artery hypertension, chronic thromboembolic pulmonary hypertension, or heart disease. Once you've looked at the risk factors and you feel this patient may be having evidence of vasculature involvement, look for clinical features. Sometimes a rapid deterioration of the disease, even though well-controlled COPD, could be a hint. Sometimes a gradual change may be visible over years, and oxygen requirement, hypoxemia, which is not explainable by the current lung condition, may be a clue. Doing pulmonary function, including DLCO here in this case, and a blood gas analysis are helpful. You can also do pro-BNP measurements, ECG and echo to look at the right heart component, and imaging, whether it's in the form of CCT, SPECT or VQ scan when you suspect a thromboembolism, or in selected cases an MRI can help you assess whether you need a right heart catheter. In setups where it's available, cardiopulmonary exercise testing is helpful and guideline recommended for assessing ventilatory or cardiac limitations in these patients. What will be the indications for a right heart cath in lung disease? So for those of you who are studying for exams, this is a very important question to answer. In your patients with COPD or ILD, when you are assessing them for a surgical treatment, for example, a lung volume reduction surgery or a lung transplant, then it is very important to assess the vascular component, and so right heart catheterization is indicated. For patients where you suspect pulmonary artery hypertension or chronic thromboembolic pulmonary hypertension, again right heart cath is indicated. And in those patients where therapeutic interventions will be determined based on the further assessment, you should go ahead and do the investigation. Coming to therapy now, it's important to optimize the treatment of the underlying lung disease, and that's the first thing to do. Secondly, you may need supplementary oxygen, NIV, and you also need to enroll your patients into pulmonary rehab, which will improve their exercise tolerance. In cases with COPD and emphysema, amongst various trials done, one of the very prominent trial, which was a 16-week randomized controlled trial in severe pulmonary hypertension, sildenafil has been used, and sildenafil therapy has shown significant improvements in pulmonary vascular resistance and quality of life. In fact, it is shown that about 30% of patients with COPD and severe pulmonary hypertension in the registries have been treated with PDE5 inhibitors. So the consensus is that there is some role of PDE5 inhibitor. It can also improve the transplant-free survival in some patients, but the guidelines recommend that it is based on individual decision making and not a part of routine recommendation. In contrast, when we talk about patients with ILD and pulmonary hypertension, there is evidence for negative results. There are studies which show that endothelin receptor antagonists in ILD patients with PH will have a negative impact. Sildenafil also has been shown to have a negative impact in ILD. Ambrisentan has been shown to risk clinical worsening in these patients with or without pulmonary hypertension. And riociguat has shown increased clinical worsening, excessive mortality, especially in IIPs. So, the recommendation is that the routine use of medications approved for pulmonary artery hypertension should not be done in patients with ILD and where the pulmonary hypertension part is non-severe. There is a promising result with an increased study on inhaled treprostinil where there were improvements in proBNP and there were improvements in clinical status of the patient. So this may be some therapy to look out for in future, but take home message from this slide is that the routine use of pulmonary artery hypertension medications, even sildenafil, should not be done in ILDs. Eligible patients should be evaluated and they should be referred for lung transplant if it's indicated. So these are the recommendations, the table from the guidelines, most of it I've already discussed, and this usually has a good class of evidence in terms of evaluation and optimizing therapy for the initial disease. And as I said, in ILD patients, for non-severe pulmonary hypertension, we do not recommend drugs, but the recommendations give a conditional recommendation for patients with severe PH and ILD, where PDE5 inhibitors may be considered based on individual decisions. But in non-severe PH, you would not preferably do that. So, this is a summary of the major changes and recommendations in Group 3 and patients with CTD lung disease. This ends our pulmonary hypertension series, and for more information you can look back at one of these previous videos and go back and see the guidelines for diagnosis and the diagnostic testing followed by the treatment. I hope you enjoyed this pulmonary hypertension series. There are a few topics like chronic thromboembolic pulmonary hypertension which I feel must be touched upon, and I'll soon come out with a video on that. For any more suggestions on topics and videos, please comment in the comment box and let me know. Thank you, happy reading, and I hope this keeps on helping you all.